Assalamu alaikum. Good evening, everyone. First, I would like to express my gratitude and thanks to Dubai Health Authority and His Excellency, Dr. Hamid Al-Qatami, as well as the organizers of the Dubai Health Forum for inviting me to speak before this fantastic and distinguished audience. My talk is going to be about health financing, challenges facing rationalization of health expenditure. And actually, I'm going to start from where my colleague Mark has ended, that low and middle income countries should have a different path than developed economies in order to avoid a costly path towards universal health coverage. And the question that comes to mind is, why should we care about rationalization of healthcare expenditures? First, if we look at the data, globally, 7.2 trillion US dollars are spent on health, which is about 10% of the global GDP. But health spending is rising exponentially. When you look at, this line in the middle, which represents average growth of GDP per capita, and all the countries are above this line. That means that health expenditures is growing much higher than GDP. And this is true almost for all the countries in the world. Between 2000 and 2015, the annual growth rate of health expenditures was 4%, while GDP growth was only 2.8%. And I'm sure now you're familiar with this chart that Mark has presented. We unpacked the countries by income, and as you can see, consistently across the board, health expenditures at all income levels is higher than per capita GDP growth. And it's particularly high in low-income countries and lower upper middle-income countries. And that's a challenge. When we look at the share of domestic resources, what governments are allocating for health, and when we also divide it by income levels, we note that current health spending trends will put more upward pressure on public finance, particularly, again, for low-income countries and lower upper middle-income countries. So on the one hand, health spending is rising very fast in those countries, and at the same time, what the governments are putting is lower than other countries. Now, there are several factors that contribute to this rise in health spending. First is income growth. As countries become more prosperous, health spending also increases. Second, aging. People now live longer, and when they live longer, of course, they consume more health, and usually this is more costly. Epidemiologic transition. Now we're suffering for more non-communicable diseases, cardiovascular diseases, cancer, diabetes, and so on. And again, these are more costly. Technological proliferation. With the proliferation and the increase of medical technology, which is useful, but also more costly. And finally, people now have more access to information through internet and other means, and they require, and they expect and demand more services. So these are the factors that drive the increase in healthcare costs. Now, the question is this sustainable? Of course not. What can we do? And one aspect that is usually not looked at very carefully, and I'm glad that Fred Butler actually touched on that, which is addressing waste. There is a lot of waste in the health system. About 20 to 40% of health spending is wasted due to inefficiencies as well as inappropriate allocation of resources. And in the middle, you will see a number of examples of some of that waste. It is estimated that in low and middle income countries, waste due to human resources is up to 38 billion US dollars. Medicines, up to 13 billion US dollars. Waste in hospitals, up to $27 billion, and leakages, another $27 billion. So this is where rationalization can start. Now, let me also then probe a little bit into some of the examples, both at the health system level, at the macro level, as well as the point of care, service delivery level. This chart looks at the percent of administrative cost in different countries divided by different schemes. So the bottom green, gray color is government schemes. Then you have the compulsory health insurance schemes, social health insurance schemes, and then on the top you have the voluntary health schemes. And as you can see from this arrow, there is a large variation from 1.2% in Iceland up to 8.1% in the United States. And the analysis shows that multi-payer systems and private health insurance have higher administrative costs than single-payer systems, mainly due to lack of economies of scale. And also, not necessarily that this higher cost means better health system performance. Also, when we look at out-of-pocket spending, again, we have unpacked or decomposed out-of-pocket spending by income level. And as you can see, it is the highest in low and lower upper middle income countries, 43% and 38%. And this is the most inefficient way of financing health resources. So as you can see, low and lower middle income countries are faced with a lot of challenges. And one way of trying to help them achieve universal health coverage is through rationalization of healthcare spending. So, and another example is fraud, corruption, leakages, and abuse of the system. There is a perception globally that 45% of the citizens perceive or believe that the health sector is corrupt. In OECD, is about 1/3 of the citizens. In fact, analysis had shown that on average, we lose about 6% of health expenditure to fraud. And again, this is yet another area. Now let's look at the service delivery point or service delivery level. And there is actually waste at all levels, starting with access. So people may not have access to health care at the outset, maybe due to lack of physical access or financial means to actually reach these facilities. And even when there is access, the intervention may not be available. In the previous case, 400 million, the World Bank has estimated 400 million people don't have access to basic care. In the second case, when they have access, the intervention may not be available. Up to 86% in sub-Saharan Africa cannot get needed surgery. And even when the intervention is available, it may not be provided or offered. And finally, even when it is offered, patients do not adhere to the treatment protocol and taking the medication on time. For example, these are 4 countries that show cascade analysis, starting from those who are aware that they have hypertension. And as you can see, there is a variation between 20 and 80% who know that they have hypertension. The rest don't know. And even from those who know that they have hypertension, a smaller percentage or a lower percentage are put on medication. And even those who are on medication, they don't take it regularly, and therefore you see that their hypertension is not controlled. This is yet another area where we can improve services as well as save costs. In hospitals, there are several areas of inefficiencies. First, avoidable hospital admissions. People are admitted to hospitals where this care can be provided in outpatient services. Also, avoidable hospital stays. People are admitted into acute beds while their case can be treated in day surgery. Longer hospital stays cases that require only 5 days of hospital stay, they stay for 6 and 7 and 8 days and sometimes longer unnecessarily. Also, institutionalized hospital stays versus home-based care. In some instances, particularly in surgery like orthopedic surgeries that require longer stay for rehabilitation and physical therapy, we don't need to put the patient in acute hospital bed. These can be moved to either home care or long-term care. And finally, avoidable hospital readmissions due to errors. On the last one, for example, okay, before moving to the next one, by being more efficient, hospitals could actually achieve 15% more with the same resources. So yet this doesn't only reduce cost and save money, but also improved outcomes. This is an example of hospital admissions for chronic conditions such as diabetes. And as you can see on the right side, all those who are above average means that these may not be necessary admissions. Similarly, longer stays or readmissions from post-operative sepsis. As you can see, people are either, or patients are either readmitted or they spend more stay in hospitals simply because lack of sterilization, adequate sterilization, and due to hospital sepsis. Pharmaceuticals is another area where we can rationalize health spending. And there are several factors. First, low use of generics, over-prescription, redundant prescriptions, when people have access to different facilities and different doctors, so each doctor prescribe this more or less the same drugs, but maybe different brands for the same case. Unused medicines at all levels, in hospitals, even at our homes. Think of how many discarded medicines we have sort of discarded because they were unused. And finally, inefficient stock management. Now, if we look at the percentage of funds that are spent on pharmaceuticals, it accounts for about 15% of total health spending, and it goes up to more than 20% in low-income countries. A study has shown that we can save up to 60% on average if we just switch to generics. And these are some of the countries where they spend, this is the amount that can be saved in each of these countries if they use or they switch to generics. Also, antibiotics, the inappropriate use of antibiotics. Across the board, it is estimated that there is inappropriate use of antibiotics of about 50%. And this analysis shows this range across different services. And it can reach up to 90% in general practice. Not only it is a waste, but also the inappropriate use of antimicrobials and antibiotics lead to resistance, and therefore it becomes more difficult to treat these patients, and they require even more costly interventions and treatment. So, what are the strategies to improve rationalization of health expenditures? Well, from international experience, there are a number of strategies that many countries have adopted, and I'm going just to list some of them. First, allocate more resources to prevention and primary care. Of course, I don't have to say this in this forum because I'm sure you already know that. But I think what's more important here is that the use of behavioral economics and nudging and behavioral insights to be able to change the behavior of people as well as clinicians. And second, reduce the fragmentation in revenue pooling and collection. If you have too many financing schemes, it is more likely to be less efficient. So the more you consolidate at the revenue collection and pooling level, this is more efficient. Introduce prepaid schemes to reduce out-of-pocket spending. As I mentioned earlier, this is the most inefficient way of financing healthcare. So it is important to find or to develop and devise prepaid schemes to be able to pool this out-of-pocket spending to make it more rational. Also, improve governance and accountability to reduce corruption and abuse. This is, again, another important element because that, as I have shown, the loss of funds to corruption and fraud is relatively high. Increase financial protection for the poor and vulnerable. Introduce strategic purchasing, like pay for performance, to be able to reduce inefficiencies at the point of care. And we've seen some of the examples. Paying providers or hospitals fee for service or a budget or salaries, it's not that efficient. They will not change their behavior. So it's important to have a mechanism to link payment to performance, and this will reduce inefficiencies. Also, we need to encourage the use of generic medicines, introduce or expand the use of health technology assessment. Many countries, including in the OECD, about 19 countries in OECD, and many countries around the world, have either established a unit or a department or even an independent agency to assess the cost effectiveness of any new medicine, drug, or any new medical intervention or medical equipment. And finally, and this forum has extensively covered this topic, the use of technology, but at all levels. First, to inform citizens and empower patients so they can make their own decisions. And we've heard a lot about the wearables. I don't have one, but you should consider it. Support clinicians and improve care coordination and outcomes. So these are some of the strategies that governments can adopt and think about in order to improve rationalization of health expenditures. However, this is all good simply because these are sort of technical solutions, but reality is different. Health policy makers are faced with lots of politically challenging factors. First, the political considerations. Reducing waste is not really a compelling concept. It's not really an attractive notion. Second, there are no clear winners. In any reforms, you have to have winners, whether organizations or people, so that these can support your reform efforts. When you say reducing waste is not really that appealing. Also, when we talk about rationalizing health expenditures, the perception is that means that the budget is going to be reduced. So people will be resistant to such reforms. And usually standalone efficiency reforms are less effective. If you just focus on hospitals or provider payments, you're not going to get much gains. So you're going to lose momentum in terms of implementing these reforms. And finally, these reforms, or any kind of reforms, are contingent upon a window of political opportunity. You cannot do reforms all the time or at any time. And there are also another set of trade-offs. Policymakers, even when you have an extra dollar from savings, where I'm going to allocate it. So there is this trade-off between interventions and coverage. Do I allocate this extra dollar to, let's say, antiretroviral treatment, or to more campaigns, mass media campaigns? Also, another tension is between coverage and financial protection. Do I cover more people or protect more people? And again, the classic one between curative and preventive services, between personal and community services, and even between services and systems. Do, again, I improve services or expand services, or strengthen health systems? And finally, even at the macro level, do I allocate these savings, or even if I have extra money, to the health sector or education or building road or better access to clean waters? So what's the way forward? First and foremost, there is no blueprint for reforms to rationalize healthcare expenditures. So while global experience and best practices can help inform these kind of decisions, each country has to chart its own way, its own strategies based on its political economy environment. So there is no blueprint. We have to look at what has worked elsewhere, but how to make it work in our country will depend very much on adapting and adopting these strategies to the local context. Second, it is more pragmatic really to sort of package these reforms as part of a broader set of reforms, not just focusing on improving rationalization. And finally, it is important when you communicate these reforms, you focus on the impact, not on cost reduction, but how many people are getting more coverage and how many lives are being saved. Thank you very much.